Thanks a lot, Beth. I appreciate that. It's, for me, really cool to be invited here. Thanks for all you guys for coming, but particularly, we're up in the lab doing cases all morning, and we have this up on the webcast, and it's cool for me to see all the people, like the whole team that we work with, kind of up here presenting data, really, disseminating a lot of the things that we think are best. So just to be part of that's great, even on a day-to-day basis. I'm 15 years out from my fellowship, and I spent 5 years here, 5 years somewhere else, and I really missed it and came back, and the differences are palpable, so it's cool. So it's great that all you guys are here. I hope this helps a little bit. With that, I'll get started. I gave this talk last year. I was a couple minutes over, and I added like 30 slides, so I'm pretty sure that's going to work out great. I'm half joking, but okay. So my disclosures, I work for these, or I consult for these companies. Radial intervention update, that's the title. So here's a quick outline. We'll go through it as we go. So we'll start with a brief history rationale. It makes sense. So again, I don't want to go to all the details. We've been doing this for a long time. Really in the late 80s, early 90s, Dr. Campo really started publishing on the feasibility of doing radial angiography. And then in the mid-1990s is when PCI really started taking off there. But it was still kind of like a niche procedure. There's a big rationale for using TR for intervention. We use a lot of blood thinners for these cases, as you know. Bleeding is an important, infrequent, but really important problem. It's associated with bad things, mortality, MI, stroke. And TR reduces bleeding, so there's some plausibility here. In addition, patients prefer this. You can get up right away, get out of the hospital sooner, and then bean counters like it. So looking at bleeding rates, they're really related. Anyone who has an invasive procedure can bleed, but they're really related to presentation. So these are pie charts of bleeding for presentation. So 2% in stable angina, 5% and 12% in non-STEMI and STEMI. And this is broken down. There's a lot of non-access bleeding, which is red, and access site bleeding, which is a major proportion. This is from NCDR, which is, as you all know, a very large data set. This is a meta-analysis of bleeding in ACS patients. It just shows that when you add all this data together, it's 130,000 patients, people who bleed don't do well. This is an odds ratio of 7.6, or 7.6 times more likely to die if you bleed when you have your ACS, so this is super relevant. What about where you bleed? Well, this is adjusted. Of course, if you bleed outside of your access somewhere, that's probably something, if you bleed in a brain or GI bleed, which is a big predictor, but even access site-related bleeding, so induced bleeding, is relevant, significantly relevant to your outcomes. It's not just death, MI and stroke, huge odds ratios for these bad things if you bleed. So not rocket science, but bleeding is bad. This just shows the effects of transradial versus transfemoral. Again, this has been repeated many times. These are several different studies, thousands of patients. There's less access site bleeding. Even the transfemoralists don't debate this. There's a 70 to 80% reduction. So all that history and rationale is there. But you really want data, prospective data on outcomes. And this is where the powerful stuff comes as to changing practice. So we really started with the Rival study. Many of you have heard of this. It was 7,000 patients with ACS and STEMI. They were randomized to radial or femoral access. And they looked at a composite endpoint, MACE, which is death, MI, and stroke, and bleeding. So that makes that NACE, net adverse. I'll use that term a lot. So they didn't show a difference in this study, meaning they were equal, slightly less in the radial group, but not different outcomes based on access site. And we'll get into the minutia of this in a second. They did show that major bleeding, by their definition, was equal, but it's a very strict definition, TIMI, non-CABG major bleeding. When you use more standard definitions of bleeding, there was a marked reduction in radial bleeding, as you can see. And vascular access site complications were much less. Sorry. What was provocative was in the subgroup analysis of the Rival trial, we saw in STEMI patients, in particular, the half that had STEMI, or the third that had STEMI, there was a huge reduction in mortality, 2%. Radial versus femoral, an absolute reduction. That's really powerful numbers, as we'll see. That led to a lot of other trials that were designed for STEMI only. This is a STEMI radial patient trial, 700 patients, radial versus femoral in the Czech Republic. Their endpoint was just bleeding and access site complications, markedly reduced. It's supposed to be 1.4. Their MACE, so all the ischemic outcomes, were not statistically lower, but it wasn't powered to look at that. And when they combined the bleeding and the MACE for NACE, there was also a marked reduction. The rifle trial was pretty eye-opening for people that came later. Italian study, 1,000 STEMIs, femoral versus radial, again, pretty standard randomization. They used really, really sick patients. Everyone got randomized, even if they were in shock, if they were unconscious, they would talk to family. And they had marked reductions, radials in the gold here, in NACE and bleeding. When they looked at the MACE composite, so the components of the major adverse cardiac events, usually these things are driven by the softer endpoints, target lesion, revascularization, things like this. But this outcome was driven almost entirely by cardiac death, a 4% absolute risk reduction. So this is hugely, provocative. Again, the bleeding was all reduced in terms of access site bleeding, as we would expect between those two. So it wasn't really until the Matrix trial, I think, which was more comprehensive, larger, where really things started changing, at least overseas. This was a complex randomization of radial versus femoral in STEMI and non-STEMI patients, and they sub-randomized to bivalve versus heparin and the dosing of bivalve, which we're not going to talk about. They looked at both MACE and the added major bleeding endpoint to make NACE at 30 days. What they saw was a significant, important reduction in MACE, but they defined their significance as 0.025, so they were even more stringent. So it was 0.03, so it technically didn't meet significance. The NACE outcome, of course, did when you added bleeding, 0.009. So this is, again, 2% reduction at 30 days, which are, in our world, very huge absolute changes. Concurrently with this trial, they published an updated meta-analysis of the cumulative data that had been accrued to look at the effects of radial versus femoral. And if you can look here, death, this is the cumulative data, 0.72, indicates there's a 28% reduction in death if you went transradial for ACS-PCI, without a concomitant increase in stroke, which was some people were concerned about. So there's more outcomes data. They looked at a lot of different other endpoints with radial versus femoral, mostly through Matrix. When you have these large trials, there's a lot of sub-trials that come from them, a lot of data that comes from them. This was 8,000 patients again. So they looked at kidney injury, radial in the blue, femoral in the red, so a 2% reduction in AKI, defined either as a 25% increase or a 0.5 increase in creatinine. Interestingly, the benefit in reducing your risk of kidney injury going transradially really was felt by those who were most likely to have kidney injury. So those who already had CKD, GFR less than 60, older patients, 75, sicker patients, KILLUP class 3 or 4, so more advanced heart failure, and those that had a Moran score greater than 10, which is a predictive risk of CIN. So really it's the sickest patients who tend to benefit, as we'll see moving forward here. So what's the counter argument? I don't know. I could do a poll here of who lab radial versus femoral, but there's like two giant lights, so I wouldn't even know what the results were. So I imagine many of you work in femoral labs, if the numbers of America stand true to this room. There's a counter argument, and one of them is experience, which is fair. So what does experience have to do? In Matrix, the benefits that we're seeing when they split it by centers proportion of radial PCI, it was only seen in those centers that did a high proportion of PCI, which makes sense. Practice makes perfect. It's not rocket science. This isn't an argument to say, I'm a low proportion radial PCI center, therefore I don't get a benefit. It's kind of an argument to say maybe I should become a high proportion radial PCI, but that's a separate conversation. So both MACE and NACE were really only seen in high center proportion radial PCI, which is important. That was also seen in Rival. The primary outcome, which was negative between the two, were equal. When you look just at the high centers, there was a marked benefit of their primary endpoint with radial access. To that end, our European colleagues have published a clear graded level of increasing your competency, starting with easy cases, 50 cases, then planned PCIs that are easy, then all diagnostics, then all PCIs, then non-STEMI and STEMI patients. And really, you can achieve this over a very short period of time. So that counter-argument is soft. Another one is a new study. I don't know, many of you heard this. It's just a couple months old, the Safari STEMI trial that was not published yet but presented at ACC. It was another STEMI trial of radial versus femoral, and they looked at all-cause mortality at 30 days. That was their plan. They created the trial and expecting about a 4% mortality rate in the femoral group, which would have needed about a 5,000-person study to prove this to be true or not. These were well-treated patients, bivalve. Almost everyone got ticagrelor, which is standard of care. But this was a very not sick STEMI group. Only about 1% to 2% needed LV support. And what they found fit with that. There were very low, way lower than expected mortality rates. So after about 2,000 patients, they stopped the trial because it was futile to show a difference based on the numbers that they were occurring. This doesn't really prove that radial is equal to femoral. They stopped the trial because the rates were really low, so any two interventions would be hard to prove, and it's one piece of the puzzle. Another piece that didn't make sense with this trial was that despite decades of data showing otherwise, bleeding wasn't different between radial and femoral, and I showed you that powerful data of 7-8-fold increases in bleeding, and they didn't show this stuff. So I don't know what to make of it. I do. I just ignore it and don't change my practice. When you add this up to the other cumulative data that we showed with the Matrix trial, the overwhelming evidence is still in favor of doing transradial. And this is powerful. It's just even more powerful. It's one added study that cumulatively shows radial benefit. This is the same thing. They kind of took out certain trials to make sure that they weren't affecting the outcomes too much. So let's kind of go back in time a little bit and look at a historical perspective of benefit. I don't know, again, I imagine there's a spectrum of experience in the audience here, but those that are maybe 15 plus years out there will remember times where we just did lytics for STEMIs, or maybe 20 years, I guess now. And this was the original trial, TPA versus streptokinase in New England Journal. It showed a 1% absolute reduction using TPA versus streptokinase, meaning you give 100 patients TPA instead of streptokinase, you saved one additional life just for changing the medicine. That was big. Well, then we switched to primary PCI versus lytics. And on average, and we know this is different depending on how sick a patient is, but on average, you had 2% absolute risk reduction, meaning you treated 50 patients with primary PCI, which is the standard of care, versus lytics, and you saved one life, at different time points. What about door to balloon? We learned that if you did door to balloon in 60 minutes, as opposed to 120 or higher, you had a 50% reduction in mortality. These paradigm shifting things, they changed our whole systems, door to balloon, doing primary PCI, and at the time switching lytics. Well, where does TR versus TF fall in that? It's kind of a 2% reduction in mortality, and yet the uptake is nowhere near the way the uptake was we're shifting lytics or going to primary PCI, which is, to me, mind-boggling. This is just a strategy change. So how does this data affect the guidelines? That's what the experts, they publish documents that help guide our treatment. So these are US guidelines here. Now this is 2011, they haven't been updated. This is just the guidelines to PCI, elective PCI. It's a class 2A. So 1 is pretty much everyone does it. Well, you should do class 3, no one should do it, causes harm. 2 is kind of in between. 2A is most people do it, 2B is most people don't do it, and then the level of evidence means how much supports that recommendation. So this is a 2A level of evidence because it decreases access site complications, so that's been there for a while. Well, what about for STEMI? It's not even commented formally, it just says should be considered when feasible, which is kind of a cop-out, and they put depending on experience level, which is reasonable. The guidelines for ACS, so that previous one was STEMI, for ACS, they don't even mention it. It's not mentioned. This is a 400-page document. You can search the field for the word radial, and it comes up like 2 times for a radial A-line in the CCU or something like that. Whereas our 2015 ESC guidelines, recommendation 1, level of evidence A, the single strongest possible recommendation. It makes no sense to me. I know why it is because there's a lot of kind of forces involved. I'll leave it at that because I only have 7 minutes. So what is our current utilization? Okay, fine, I can say that. And I know I'm half joking, and it really is a process, and it's not just switch one day, but what is our usage now? And this is 2013 cath PCI, 3 million patients. In 2012, 16% of people were getting radial PCI in America. Interestingly, it was mostly men, less than 75. The growth was more in men, less than 75, stable patients or ACS, but not STEMI, and Northeast more so than other regions. No difference in procedural outcome, and here are all the difference in bleeding and vascular complications, and this is 3 million patients they were looking at. 2016 kind of updated numbers, 25% of patients in 2000. It was probably around 30 or 40. I know Dr. Sharma alluded to 50 being the new 40 or something like that. I would say like it's 50 plus 40 is 90, and that's what it should be, 90, not 50 or 40. But I'll have that conversation with him offline. So What about the temporal trends in the VA? The VA uses about 35%, which is always a little bit more advanced, I would say. The problem is that we're utilizing it wrong. This is the risk treatment paradox. So this is kind of a really great slide, I think. It shows that this is 18,000 patients. They looked at the predicted risk of bleeding from a femoral case, low, intermediate, or high. So those with the highest predicted risk of bleeding, black is femoral and gray is radial, were most likely to get a femoral procedure. So you're using the procedure incorrectly. And that's kind of what people do. Oh, it's a young, healthy person, let's just go radial. Well, that's the person who'll do fine no matter what. It's the 50 kg, 80-year-old woman who, is going to bleed. She's the one who needs a radial procedure more than anyone else. What about for STEMI? This is the growth, 2% in 2009 up to 25%, which is great. But just to put it in context, this is a STEMI study from Europe. It was really bivalve versus heparin, but just looking at it, of the 6,000 patients, 5,400 got radial procedures. So they're like 90%. So it really comes down to committing yourself to this, and I think you guys are a big part of this, vocalizing it in your lab, getting your docs and whatever to consider this for all these reasons. Patient selection is a big part of it. You don't want to do something and fail, and when you're starting, you should do things that help you succeed. So if you're older, if you've had bypass, or if you're very, very short, you're more likely to fail, so you shouldn't start with those patients. This just shows that the relationship between height and success or failure, the taller you are, the less likely you are to fail. There's more room to manipulate the catheters. Complications. Radial artery occlusion, it's important, but it's usually clinically silent. This is the ulnar. There's all this redundant circulation. So even if the artery is occluded post-procedurally, the hand is not jeopardized. We know smaller sheaths reduce the risk of radial artery occlusion in the short and long term. Technology is better. Most of you probably, if you do radial procedures, use slender sheaths, which this is 6 French sheath. You need this much room to do PCI, and this is how big the outer diameter is. Well, now we have sheaths where the outer diameter is much smaller, but the inner diameter is preserved. Why? Because they gave up real estate in the wall. It's not really complicated. And there's less radial artery occlusion as a function. What about anticoagulation? We used to say, oh, let's give a couple thousand of heparin when we put the sheath in. That's not good enough. Okay, there's a randomized trial that shows there's a dramatic reduction in radial artery occlusion if you give therapeutic heparin. So no heparin was 70, small dose 24 and 4% here. That's not the same as Coumadin. If you're on Coumadin, you still need heparin. Yeah, of course, if you're on other antithrombotics, you don't need heparin, but if you're on Coumadin, you still need therapeutic heparin to avoid radial artery occlusion. How you do your closure. When you take your catheter out, this is a study that put a manometer, and they looked at, well, if you put the pressure on the TR band, the closure device, just above MAP versus twice MAP, so you squished it and you occluded it, there was 0 bleeding. Well, there was also 12 times more radial artery occlusion. So we want patent hemostasis. How do we check that? A reverse Barbeau test. So what we do is we put our closure device, make sure we have hemostasis with just enough air, occlude the ulnar, and if this is open, you should still see a waveform there. And when you do patent hemostasis, short and long-term rates of RAO, radial artery occlusion, go way down. There's newer stuff. When you put the TR band, even purposely compressing the ulnar artery for 1 hour, this study did that, and this is several thousand patients. They had way less reductions in radial artery occlusion. The numbers are higher because this was ultrasound. It wasn't even clinically. Everyone got an ultrasound to check. Spasm, this is very preventable. Adequate sedation, small sheaths, vasodilators. This is some of the risk factors for it. I'll speed up here. This is just an angio example of how different how the vessel can respond to the medication. So here, catheters go easily here, and they might cause discomfort here. This is an ultrasound of the same artery. You can see the lumen area post-verapamil is much bigger. There's no benefit of long sheaths. It causes more spasm. Hydrophilic sheaths are important, and the sheath ratio is important. These are end-stage complications, but sedating a patient sufficiently. I've had 1 in 15 years, one case of true entrapment that required a regional nerve block, and we were still able to get it out. Solution, prevention is best. Just wait, sedate, pain control, so on and so forth. Perforations are important. There's millions of little tiny branches, so using favorable wires like J-tip wires are important. It's a rare complication, but can happen, usually easily manageable, more commonly in the elderly hypertensive patients, friable tissue, anatomic variants, and so forth. There's different grading systems of whether there's a hematoma, how far. It's really important. We generally just have a non-invasive cuff, and that can control the brachial artery, and then you can apply compression elevation. Rarely you can get compartment syndrome, but if you do all the things properly, generally this doesn't happen. What about the experience, not the operator experience, the patient's experience? Well, forever we've had data, this is really old, you can tell by the slide, quality of life measures as reported by the patients, all different quality measure, pain, functionality, vitality, all these things better with radial than femoral. Interestingly, I find it's really, in the Rival trial, you remember 7,000 patients were randomized. They asked the patients who were randomized to femoral if you had, and who did not have a complication. If you had to have another procedure, would you be okay with a femoral procedure? And I don't know what the exact words were. And the same with the radial. So 50% of femoral or randomized patients did not want another femoral procedure, even though they didn't have complications, whereas 90% preferred another radial if they were radial. I mean, this is pretty solid data, and this is what we see in our practice too. People absolutely, many patients request this now. What about the operator experience? There's concerns about radiation, which are real, but there's a short learning curve. Fluoro time drops dramatically after about 50 cases. This shows that there's less differences in radiation based on your volume. So once you become a high volume operator, there's really no differences. The RAD matrix trial was a sub-trial of the matrix trial, which did show slightly higher radiation for the operator this is. At the thorax, there was no difference between left and right radial arteries. I'm zipping through this because my time's low. There was a big meta-analysis done on this to look, and this just shows a really important point, that over time, these are all the different studies they looked at, over time, the difference in radiation excess with radial procedures for the operator is diminishing, and it's just a function of experience. This shows that in low volume operators, there was a 13% difference versus a 7% difference in high volume operators. This is left versus right. Left is much more uncomfortable than right for operators, but there is more radiation from the left. From the right. So to that end, we published best practices. This is really being good about the camera. I personally will always ensure everyone's leaded before we start, but it's really how you use the pedal and the II and not fluoroing the wire going up the arm and not doing cine, using fluorosave. So technology is going to solve this a lot. In the end, low radiation operators are low radiation operators, whether they're femoral or radial. So lastly, from the hospital perspective, bean counters, as we refer to, they love this. This is length of stay by bleeding risk. So this is all patients in this trial of, this is NCDR model, so many patients. Average of 0.4 days. So that's a lot. That's like 10 hours or something like that, 8 or 10 hours. And that's a lot of manpower, room, staff. I mean, that's a lot of value to people. And it was greatest in those with the highest risk of bleeding, as we saw. This is the dollar amounts, 800 average saved, 1,600 in the highest risk patients. Britain did the same thing, 300,000 patients. They saw an average savings of 250 pounds with radial versus femoral, mostly driven by length of stay here, 200 pounds. So in summary, it really makes sense. We went through the rationale. It's good for the patient. It's good for the staff. All of you guys we're all in a business that we feel well. We feel good when we have done well for a patient. And it's just good for the hospital. So not sure why we're at 40%. There's other reasons, but so thanks for your attention. I'm happy to take any questions. Yeah.